We're quite tight for time on this session, so I will hand over straight to Juliet and then we'll take some questions at the end.
Great, thank you so much. Very excited to be here with you all. We're going to go quite fast, but I promise you it'll be a fun ride through what's known as value-based care. Just a reminder, you have the live Q&A option through your app, so go ahead and drop some questions and I'll hang out afterwards in case anyone wants to talk a little bit more. This session is called Value-Based Care is putting GPs back in the driver's seat, because you heard a little bit about Sally Lewis in her opening statements talking about value-based care. And I want to both tell you a little bit more about what's happening globally with value-based care and how specifically GPs, or primary care as we call it in the United States, is really taking center stage through this movement. So I think I don't have to tell all of you that we're really in a state of global crisis in healthcare. There are multiple challenges all across the world. My work takes me to all 4 points of the globe, and I find it remarkable that we're all dealing with the exact same issues. You have a multitude of issues. I won't dive into this today. I think you know them all. But there is one commonality from all of us, is that we're all facing nations who have healthcare systems that are simply put unsustainable. And if we want to find a solution to this, we need to think more broadly about our payment mechanisms and what do we actually value in our healthcare systems. This can feel very overwhelming. I think this has been a big part of this conference, is talking about provider burnout, but just also the overwhelming feeling that most GPs feel. I trained as an anthropologist, so Margaret Mead is part of my group. You've probably seen this quote before. I have a clever little edit to it. I actually think we shouldn't doubt that a small group of thoughtful, committed family doctors can't change the world. And I want to show you a little bit about how this is happening. The example I'm going to give you is in New York. So in New York State, which I was a part of the government there, right after the Great Recession, this hit New York State particularly hard because of our financial services industry. And Medicaid, which is our public health insurance program, covers about a third of our state population. So as much as you'll hear that we're not a single payer system, I would argue that we really are, because a third of our citizens are on Medicaid, another third is on Medicare for our elderly populations, and only about a third of our population is actually covered through commercial insurance. And we had this really big challenge, which was we had an unsustainable healthcare system. We were spending too much and we were getting too little for those outcomes. And we launched what is still today the most ambitious healthcare redesign program in the entire world, where we set very clear goals for ourselves. We said, in 5 years, can we actually reduce waste in the system? Can we actually reduce avoidable hospital use, avoidable emergency care use, and bring down the per recipient spending? A lot of people thought we were insane to set this goal. We said in 5 years, could we bring all of that down by 25%? At the end of the 5 years, you can see our results here. Just a reminder, this is against a very large population. Several million New Yorkers are on the Medicaid program every year. We saw an 18.1 reduction in what we call preventable readmissions, and also a 26.1 in potentially preventable admissions rate. That's hundreds of thousands of people who did not end up in hospital because we reinforced the healthcare system and we redesigned it to support primary care physicians specifically. I want to give you one very tangible example of this. Somos, which means we are in Spanish, and obviously New York City has a large Spanish-speaking population, was one of these groups who participated with us to build this healthcare reform system. There's about 2,500 independent GPs, which if you know anything about the US, we don't have a lot of independent GPs left. This is the largest group in all of New York State. They came together, they banded together, and they were one of our highest performing provider groups in this attempt at reform. They see about 1 million patients annually, and you can see some of the statistics that they helped lead here. They reduced emergency room visits by 35%, and they also have a litany of clinical outcomes, which I will not list out for you, but it does include 30% reduction in dialysis for their diabetic patients. But more important than all of this, they actually got to full financial stability. And this is what I want to give you a little bit more context for how this works. In a value-based system, we often talk about moving from volume to value. And what that really means, I think sometimes we say that as though that makes perfect sense for everybody. What that really means is you must change the reimbursement system under which GPs practice. In a fee-for-service system, which is the system that we're stuck in now, the more services are provided, the quote-unquote more money a provider makes, right? And that puts GPs, who are typically, it's a lower dollar effort in the current healthcare system, really at the bottom of the food chain. In a value-based system, we don't pay for every encounter. We actually establish budgets, they're hypothetical, we call them sort of digital budgets, around every patient, based on what we know about them, based on their diagnoses, based on their historical spend. And what we say is, we trend it as well, right? We don't keep everything cost neutral, we add a little for future healthcare costs that are rising. But then when we have a budget, we turn around and we say to GPs, you're in the driver's seat. You tell us what this patient needs. And you're the one managing the cost. And so GPs end up making really great decisions, as you make every day. But you make really great decisions that ultimately impact the bottom line spending that we spend per recipient. So just some basic visualizations, right? In a fee-for-service space, an individual physician, whether they're primary care or not, ends up providing a certain set of services. But of course, we've got multiple different providers. You all know this. We have a great GP in the audience who has a great poster. I met him yesterday, how he's working to reduce over basically polypharmacy, understanding where are people being prescribed too many, how do we reduce that, right? But this is the current state that we're in. There's not a lot of coordination. In a value-based care model, that all flips. Because if there's one singular budget for a specific patient, suddenly, and I know this is very New York, but we call the primary care provider the quarterback, right? They become the person who's managing this person's care and making very specific decisions about what types of treatments and when, and they're managing that patient much more holistically. Here's where it gets interesting. The dollars that are saved against that budget are immediately reinvested into that GP. This is what enables the system to become more efficient and enables the redirections of funds back into primary care practices. This is really that momentum building that we're looking for all across the world as systems move from fee-for-service to value-based care. This means you don't have to apply for a grant. This means you don't have to seek extra funding. A really great example of this, Montefiore, which is an integrated care system in the Bronx. The Bronx in New York City has the highest rate of asthma, admissions, readmissions, ED. Montefiore Health System is in this value-based model. And what they discovered, looking at their data, is that they had a lot of admissions and readmissions when the outside air temperature hit 80 degrees. That's 32, I believe, Celsius. What they figured out was a lot of folks were living in low-income housing and did not have air conditioning. And that was exacerbating COPD, that was exacerbating asthma. And so Montefiore, because they're in these value-based payment arrangements, didn't have to ask anyone, they didn't have to apply for a grant. They just went out and bought air conditioners. And they started installing them in people's homes. An air conditioner in the United States is about $400. Every time they're saving on an ED or an admissions, you're saving thousands of dollars at a time. So this is what I mean by putting the GP really back in the driver's seat, is when you don't have to play in the fee-for-service world, you get to make the best decisions for your patients. And sometimes that's going to be treatment-wise, a clinical treatment, and sometimes it's going to be a social treatment, social prescribing, replacing an air conditioner, figuring out a better housing solution for someone. We know all of these things work, but without the flexibility of value-based care, you today are unable to do these things without additional federal funding. Somos is one of the world's leading value-based care organizations. As I mentioned, they participated in this payment reform effort that we had in New York State. They are now in what we call full value-based payment. They own 100% of the insurance risk, if you want to think about it that way. They manage global total cost of care, and this has enabled them to be incredibly resilient. When the COVID-19 pandemic hit, as you all know, in a fee-for-service environment, a lot of primary care doctors were not receiving revenue, right? You were not seeing patients. There was zero revenue coming in. Because Somos was in a value-based arrangement, they had already been paid because they're out of that fee-for-service hamster wheel. And so they immediately went to work and they started testing and eventually vaccination sites for our most vulnerable populations in New York City. They also provide lots of social care in our communities because that's what they can do with all of those reinvested funds. On top of that, they've launched a national and international campaign. It's called Thank You Doctor. It's really born out of this need that I think we all feel to say thank you to primary care or GP doctors all across the world. They've gotten great traction with this. Lots of different organizations are signing up. The QR code in the bottom left-hand corner there will take you right to their site. And we're also doing a quick survey to hear about burnout and other challenges amongst general practitioners. So I will leave these two QR codes up on the screen, and I'm happy to take any questions you may have.
Brilliant, thank you very much. Really, really interesting talk. I'm just waiting for questions to come up on the iPad on the Q&A. I've got a question first, if that's okay, just while I wait for them to load.
No questions in the app yet.
Okay, so a question about data. So if we're in a situation where you're making, a decision about the budget allocated to a patient based on healthcare data, in your system, where does that data sit and healthcare data. So in your system, where does the healthcare data that informs budget allocations for patients sit? And how does that kind of practically work, if you can answer that?
That's a great question. And then I will take Emma's question that she submitted. The question was really around data. Data is not interoperable in the United States. I don't think a single country outside of Estonia has really a fully integrated data system. What we do is, depending on the insurance, so we're talking here about public insurance called Medicaid. Medicaid owns all that data centrally. They share it directly with the providers. We're on about a 2-week lag. So if a patient, had an encounter, the provider will know it about 2 weeks later. We're always working to make that faster and faster. If the program is a Medicare program with the federal government, it'll go a little bit faster. We now have fully integrated APIs. And I'm happy to take that question offline if someone wants to go a little deeper. I know that's...
Brilliant, thank you. So the next question in the chat is, what happens when a patient unexpectedly exceeds their budget, and how is this accounted for? Yeah,
great question. So in value-based care, not all agreements are what we call full risk. So the Somos provider that I was telling you about, they're in the full risk arrangement type context. So they're at 100% what we call upside or downside risk. So every dollar that they save, they get to keep. Every dollar that they lose, they have to pay back. That is not where providers start in value-based care. We start at very lower levels of risk, where the downside risk is either 100% insured against, so the providers don't owe anything if they go past the budget. But in future years, as the providers get more experience with value-based care, they take on more downside risk. And as time goes on, they do get to those higher levels of risk.
Thank you. And so there's one more question in the chat, which is, what do you think implementation of value-based care could look like in the UK?
Yeah, this is a great question. Thank you, Fraser, for asking it. There's a lot of excitement around value-based care in the UK right now. To be fully transparent, we had a 10-year learning collaborative with the NHS with the work that we were doing in New York. They were interested in seeing how it could be applicable to the NHS. I'll just say quickly, because I'm out of time, but I will stay back and answer your questions. I think there is some excitement around it in the 10-year plan. There is not enough definition right now in the 10-year plan. It's sort of alluded to. And I would say the biggest thing I can ask you all to do is be advocates of this work. but make sure that the terms are fair to you all. And I do have to stop there because I'm getting this motion, but I'm happy to talk more and take your questions, and I will hang out right here. Thanks so much, everybody.
Brilliant. Thank you very much, Juliet, for your time.